You're listening to Medscape's In Discussion series on Idiopathic Pulmonary Fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, Professor of Medicine in the Interstitial Lung Disease Program at National Jewish Health in Denver, Colorado. Dr. Swigris directs research centered on how patients live with and experience interstitial lung diseases, how to best assess that experience, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape in Discussion on the topic of idiopathic pulmonary fibrosis, or IPF. I'm Dr. Jeff Swigris, and today we'll be discussing the use of supplemental oxygen in patients with IPF. How and how often should we test for oxygen needs? Is supplemental oxygen beneficial to our patients? And if so, how? With me today to answer these and other questions is Professor of Physiotherapy and Head of Respiratory Research at Monash University and Alfred Health in Melbourne, Australia, a Leadership Fellow at the National Health and Medical Research Council, or NHMRC. Her own research focuses on supportive therapies for individuals with COPD, chronic obstructive pulmonary disease, as well as pulmonary fibrosis. She's currently leading a multinational trial of ambulatory oxygen for people with fibrotic lung disease. She is also a chief investigator for the NHMRC Center of Research Excellence in Pulmonary Fibrosis. Anne Holland, welcome all the way from Melbourne, Australia, and thank you for taking the time for us today.
Thank you very much for inviting me. It's a pleasure to be here.
Fantastic. And your research has focused largely on non-drug therapies for patients with chronic lung disease. Those therapies have included predominantly physical exercise and supplemental oxygen. You're clearly a leader in our field in these two modalities. How did you become so committed to this work, and what keeps you going today?
Thank you for the question. I trained as a physical therapist and so had been involved in pulmonary rehabilitation programs here in Australia for some time. And I was really struck by how little we knew about the role of rehabilitation and other non-drug therapies for people with pulmonary fibrosis. And at that time, which was many years ago now, there really wasn't an accepted role for rehabilitation in people with pulmonary fibrosis. It was at the time where there weren't drug treatments available like the antifibrotics that we have now. I think there was a sense of nihilism really around pulmonary fibrosis care, and there's a bit of a disconnect for me in terms of some of the benefits that I was seeing in the patients that were coming through my rehabilitation program, and the sort of lack of enthusiasm, I guess, for this treatment. But at the same token, I also had experiences where we had some patients who were really, I think, coming close to the end of their lives, and participating in something like rehabilitation was a huge burden to them. And, you know, those burdens might not be outweighed by the benefits. So I was motivated to kind of work out what the role of this treatment was, and to work out how we could deliver it to patients who'd benefit in a way that would be meaningful for them in their lives. And I think that's rolled into the examination of other non-drug treatments, things like oxygen, where there's so much still we need to learn about these treatments. And, you know, clinical observations tell you that you have some patients who, for instance, desaturate a lot on a 6-minute walk test but have almost no symptoms. And for them, the thought of oxygen is really difficult. But you have other patients who have perhaps a lot of symptoms associated with that desaturation, and you can see a measurable benefit for oxygen in those patients. So these are really, I think, challenging clinical scenarios to work out what would work best for patients and give them treatments that would improve their lives. And that's really still what keeps me going today is trying to find meaningful treatments for these patients.
I mean, I harken back to the time that you were referring to. You're exactly right. You know, practitioners weren't thinking about pulmonary rehabilitation and exercise for our patients with pulmonary fibrosis. The programs were predominantly targeted for patients with COPD, and now it really is standard of care. And as you mentioned, it's one of the few modalities that we can use that really leads to substantial improvements in how patients feel and function in their daily lives.
Absolutely. And it's been one of the biggest changes I've seen, I guess, over my clinical and research career, that rehabilitation is now a very well accepted treatment and appears in guidelines as an important treatment for people with pulmonary fibrosis. And I still get a buzz out of the improvements that patients experience and can tell you about in terms of their breathlessness and their quality of life. So it is a very meaningful treatment, I think, for many patients.
Let's shift gears now to supplemental oxygen. Tell us your thoughts and your practices around testing your patients with IPF for the need for supplemental oxygen. How do you do it? How should we do it? How should we think about assessing supplemental oxygen needs in our patients?
Thank you. That's a great question. I think evaluating for supplemental oxygen is something that happens when we see a patient for the first time in our clinic. We have a specialist ILD clinic, so when a patient first presents to our clinic, it's something that we would consider at that time. Our philosophy around testing is that a 6-minute walk test provides very useful information around exertional desaturation. And of course, if a patient has hypoxemia at rest, that's a different story, which might point you in the direction of LTOT. But certainly exertional desaturation, I'm not sure that we've yet found a better and more robust option than a 6-minute walk test. And in fact, we've recently done some work here where we've evaluated people's desaturation walking around in daily life, where we put an oximeter on them for, 48 hours at a time. And what we find is that actually what we see in the 6-minute walk test for desaturation does reflect what happens in daily life. It's a bit worse in daily life, but we don't miss people. If we evaluate them using a 6-minute walk test, we'll detect that desaturation. I think that assessment is only the first part of the equation. There's then the discussion with the patient around the benefits versus the burdens of those sorts of treatments, which might be different across different patients. And then, of course, as you indicate, there's the re-evaluation. We're fortunate that we're able to do 6-minute walk tests often about 6 monthly or at the most yearly, so we get to reevaluate at that point. But I think there's a role for reevaluation where there's a change in the clinical status of the patient, so where they're reporting more symptoms than they've had previously, where there might be a step change in their symptomatology. I think that's a really good time to consider it as well.
Let's move on now to the actual use of supplemental oxygen. You brought up LTOT or long-term oxygen therapy, and there was a large trial conducted in patients with COPD who desaturated with activity but were not hypoxemic at rest. And this large trial in patients with COPD showed that supplemental oxygen really had no beneficial effects on the outcomes they assessed, whether it was survival, hospitalization, lung function, disease-specific quality of life. Should those data shape how we think about supplemental oxygen use in our patients with IPF?
Well, if we start first with the question of long-term oxygen therapy, I think that is a treatment for people with hypoxemia at rest. And I think there's little debate in the community that is something that should be treated and that patients get benefit for treatment. And although we don't have a lot of direct evidence in pulmonary fibrosis, I think in that situation it is reasonable to use some of that older COPD evidence regarding a survival benefit. And this is a group of patients who are often highly symptomatic as well, and those sorts of treatments that can support the advanced stages of disease I think is well accepted, and there's a strong recommendation for that in the ATS oxygen guideline. I think where it gets more complicated, as you've indicated, is where people have isolated exertional hypoxemia. And what we saw in the trial in COPD is no convincing benefits in a sort of large-scale trial for that group who only had hypoxemia when they were exercising. I think that we can note those findings. There's lots of differences for patients with pulmonary fibrosis. First and foremost, the magnitude of the desaturation with exercise, which does tend to be more dramatic in the patient with IPF than it is in the patient with COPD, and often really dramatic, actually. So I'm not sure we can take those findings and apply them directly, but I think we can certainly learn from them in terms of not assuming that providing oxygen to correct numbers, to correct somebody's hypoxemia during exercise will necessarily make a difference. And I think it makes us think harder about what are the relevant outcomes for patients as well that might make this treatment worthwhile. We need pulmonary fibrosis specific research to evaluate those questions.
Right. You hit the nail on the head. Our clinical experience is similar, and the literature would certainly support that. IPF is a completely different animal from COPD in terms of supplemental oxygen needs. These patients tend to need more oxygen in many cases, much more oxygen, and desaturate quite profoundly, and more so than patients with emphysema. Tell me your thoughts on AMBOX. So AMBOX was a relatively small trial in patients with IPF of supplemental oxygen, crossover design, 2 weeks on oxygen, 2 weeks off oxygen, no placebo control. But in that trial, supplemental oxygen was shown to improve quality of life as assessed by a patient-reported outcome, K-BILD. What's your takeaway from those results, and how should we use those data?
I think the results of the K-BILD encouraging in terms of improvements of quality of life with oxygen for people with pulmonary fibrosis. As you mentioned, it is a 2-week trial and a crossover trial. And of course, when we're talking about using ambulatory oxygen in pulmonary fibrosis, we're not talking about 2 weeks. We're essentially talking about lifelong use by the time that we start using it. So I think whilst that is cause for some optimism, it doesn't, I think, give us the information we need about the longer term benefits for patients of using this therapy, which is quite burdensome for many patients. We do quite a lot of qualitative research in our program, so we have the privilege of interviewing patients about what happens in their lives, and the burden of oxygen is something that comes up very often. You know, these are not easy devices to manage. They have an associated stigma with using them in the community. Patients and caregivers as well talk about how difficult these things can be to manage. So whilst improvements over 2 weeks is good, we probably need information, I think, over the longer term, and also information that can help patients to make informed decisions about the benefits in terms of their disease progression, what might happen in the future for things like, whether or not they'll develop pulmonary hypertension, go on to need long-term oxygen therapy. I think we still need that information that can help us have discussions with patients about whether this is a meaningful therapy for them.
And I think that's the key, isn't it? Meaningful therapy for them. Really, in patients who are not hypoxemic at rest, it's repeated N of 1 trials where you're really trying to get a sense of patients' goals, and you're trying to share with them the possible benefits of supplemental oxygen therapy in terms of how they feel and function, but also being transparent. As you mentioned, it is not without its burdens. It takes away a patient's ability to live as carefree as they would like, the stigma of being out in public with supplemental oxygen. I think there's a lot to unravel there with an individual patient.
I agree. I would really love to be able to put my hand on my heart and say to a patient, if you use this therapy, your disease will not progress, or it will not progress as quickly, and you won't need to go on and have long-term oxygen therapy, and things will be much better. But unfortunately, right at the moment, we don't have the data to support that conversation, and hopefully we will in the future. So as you say, it's really talking with patients about the potential benefits for them in their unique situation, and weighing up those benefits versus the burdens, and accepting that that is not a one-time conversation, because at this point in time, perhaps the benefits don't outweigh the burdens for a patient that's very active in the community, but that might change over time. So we need to be prepared to have that conversation again, perhaps as their circumstances change.
Exactly. I think that care of patients with IPF, we really have to be mindful that it is this longitudinal conversation, whether we're talking about going on an antifibrotic or not, monitoring disease progression with physiological variables or 6-minute walk tests, the need for non-pharmacological therapy, or the desire to participate in pulmonary rehab or supplemental oxygen. I share with my patients, you don't have to make a decision today. It's not like you're on the clock and you have 5 minutes to make a decision, and then once you make a decision, that's it, set in stone, and we'll never revisit it, and you don't have the right to change your mind. I think that longitudinal discussion, asking these really important questions about how patients are doing, how they're responding to whatever it is that we're doing or not doing, whether that's the right thing for them at that time, because circumstances change and our approach and our therapies and the way we monitor needs to change along with it.
Yeah, absolutely. And I think you've done some really lovely work about the meaning of oxygen therapy for patients and the touch points for patients. Qualitative work suggests that patients see the prescription of oxygen as a very significant moment in their journey. They often see it as a, sort of a harbinger of the end. And so it is really an important conversation to be having, to be talking about what these therapies are for, particularly for ambulatory oxygen, which is really about quality of life and activity in the community. So addressing that, but also I think addressing it in ourselves, because our work also shows that clinicians often see it that way, that they see it as a marker of disease progression and a marker of, the end getting closer more quickly. So I think we also have to examine our own attitudes and feelings towards supplemental oxygen, particularly in the ambulatory space, to be able to have meaningful conversations about potential benefits.
That's a great lead-in to my next question. So, if you have that patient who's sitting there in front of you saying, Professor Holland, just don't let me go on oxygen and I'll be okay. I can live with things the way that they are now. And, you've done your 6-minute walk test and this patient is desaturating to whatever, pick a number, 78%, and their dyspnea rating is a 7 on a scale of 10. And you might be saying to yourself or saying to the patient, I really think supplemental oxygen could have a role here. How do you talk with that patient? Can you give us some specific examples of lines that you would use and how you would approach that discussion?
For that particular patient, I think you really would want to have that discussion, wouldn't you? Because that's a patient who not only has bad numbers, they desaturate a lot, but they also have significant symptoms. And so in my head, I'd be thinking this is somebody who it might be worth giving it a go. But there's already some suggestion that for this individual, oxygen has a meaning for them that perhaps is not a positive one. So I guess I'd want to understand that a little bit first. I'd want to understand why it is that this patient particularly wants to be kept off oxygen and have that conversation around expectations and what they expect both negatively and positively around oxygen therapy, so I can understand and address some of those things. One of the really common ones still, I think, is people feel that oxygen is addictive. They feel that it is a marker that people have given up on them and that they're very concerned about what people will think of them in public. So I think it's important to sort of understand and acknowledge those things and also be able to articulate some of the expected benefits that you might see. And the way that I try and frame ambulatory oxygen and the way we've tried to frame it in our trial for patients is to say this is a treatment to help you be more active with fewer symptoms. So it's a doing treatment. It's not a treatment for your numbers, for your desaturation. It's a treatment to help you be more involved in the things in your community that you would like to be involved in, and to be able to do that in a way that you have fewer symptoms and is less distressing for you. So I think understanding what those things are that people want to be involved in is really important, because that will also guide what type of oxygen prescription might be given. And I think, as you've alluded to, again, this is not a one-time decision. So absolutely, I'd be saying, well, this might be worth having a go and seeing how you experience it and whether for you, this is something that's giving you benefits that you can feel and experience and helps you do more of the things that you want to do. But if it doesn't, let's have another conversation about that. Or if you're not ready for that today, let's have that conversation next time when you come back and have another conversation about how we might make it work for you.
I love that approach, and I'm going to steal it now, doing therapy. I really like how you refer to oxygen in that way. You mentioned a trial that's ongoing right now, and I know we weren't really slated to talk about this, but can you share with the audience a bit about the trial that you're conducting now on supplemental oxygen?
Absolutely. The trial is called the FOX trial, so PFOX, Pulmonary Fibrosis Oxygen Trial. And it's a randomised controlled trial running in Australia and Sweden comparing ambulatory oxygen to a sham device in people with pulmonary fibrosis. And we're really keen to use the sham because, of course, that hasn't been done previously in pulmonary fibrosis, and we really wanted to know whether it was the oxygen that was the benefit or whether it was the device itself. So we're randomising people for a period of 6 months, and the primary outcome for our trial is actually physical activity in daily life using an activity monitor. So again, that's tackling that doing therapy. Is this actually something that helps you to get out and about and do more of the things that you'd like to do? And then measuring, of course, those other important outcomes in terms of dyspnea and quality of life as well.
Such a great trial. I love that design. The Ambox trial that we referred to earlier, shorter, only 2 weeks, and then 2-week crossover without a sham device. So it was you're using a tank and then you're not using a tank. So clearly the potential for significant bias in the Ambox trial. Your design with the sham, I think, is incredibly bold, absolutely needed in our field, and really looking forward to that trial answering some really key questions that we've all tussled with for a long time.
Absolutely. I think there's so much we don't know about oxygen therapy and pulmonary fibrosis, and hopefully this trial will start to give us some of the answers that can then inform those discussions with patients when we're trying to help people decide whether this treatment is right for them. And we haven't really touched so much today on different devices, but there are different devices out there for ambulatory oxygen therapy, and trying to find the best match for the patient and their activity is part of that conversation as well. There are a range of devices available to deliver ambulatory oxygen therapy, and the device may be different for individual patients depending on their needs. There are, of course, oxygen cylinders that come in a variety of sizes. There are some very small cylinders that patients can carry on their backs, for instance, in a backpack that might be useful for patients who are very active. Portable concentrators that can be either carried in a bag over your shoulder or put in a backpack, which are much lighter than cylinders. They have the disadvantage that often they can't deliver very high levels of oxygen, and that can be limiting, particularly for patients with pulmonary fibrosis who have a lot of desaturation, but there'll be some patients for whom those are useful. And I think there is absolutely a need for newer, novel devices, and really hoping that there is good collaboration out there between engineers and clinicians and patients to come up with devices that are really fit for purpose for people with pulmonary fibrosis that can deliver high oxygen levels in a way that's truly portable with lightweight devices.
If somebody needs a really high flow and can get away with a smaller cylinder, I just tell them, take it to the nearest, here it's REI, but whatever outdoor store, take your cylinder with you to the backpack section. And I talk to them about the specific backpack that I want them to get. I want it to obviously fill their cylinder, but I want the weight, on their iliac crests, on what patients refer to as their hips rather than their shoulders, because I think patients feel like, I'm going to have these straps on my shoulders. So I say, take your cylinder, go into the backpack section, make sure that you get a nice backpack with a nice comfy weight strap and a chest strap that takes the weight off of your shoulders. And I think patients find that helpful.
Absolutely. I think that's a really great approach. I think the other thing that patients often talk about is the need for information and education about how to use devices. I think, for things like cylinders and portable concentrators, often the way to use them seems obvious to us because we've been doing it for such a long time, but they can be really intimidating devices for patients and for caregivers. So I think some early education around how to actually use these devices is very important in terms of people actually adopting it in daily life and feeling comfortable to use it.
So, Anne, we've come to about the end of our time. In the couple minutes left, just give me 2 bullet points that you would like our audience to take away from our conversation.
I think the first one would be that discussions around ambulatory oxygen with people with pulmonary fibrosis are an opportunity for shared decision-making. They're an opportunity for a really meaningful discussion about whether this is a treatment that is worthwhile for patients at this point. And that puts the onus on us as clinicians to be able to articulate those potential benefits, but also to be able to hear the benefit versus burden equations for individual patients. And because of my background, I'd also like to give a plug for not forgetting other non-drug treatments as well in terms of managing symptoms and helping people to be active. So pulmonary rehab, other symptom management techniques such as, handheld fans, etc., to increase airflow, other things that can give patients not only symptom relief, but a greater feeling of control over what's happening in their lives. I think those things are also important.
Absolutely. Outstanding. Wow, Anne, it has been a real pleasure, a delight to have you here today. Thank you so much for getting up early there in Melbourne and for sharing your expertise and your thoughts with us.
Thank you very much for having me. I've really enjoyed the conversation.
Wonderful. And to the audience, thank you for listening to this conversation on idiopathic pulmonary fibrosis with our guest, Professor Anne Holland. There's much more ahead in the coming episodes, so be sure to check out the Medscape app and share, save, and subscribe if you enjoyed this episode. I'm Dr. Jeff Swigris for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.